Hello, friends. Good evening. Now, the COVID is raging in the country, and I had many requests that I should speak on COVID 19 medications during pregnancy, the effect on mother and fetus, and many PGs requested me that I must also talk about vaccination. So, I thought it's a very important, current, hot topic, and I must clarify whatever I know with all of you. So, as you know, that this is a lecture series started this year on the request of KMC Manipal postgraduates, and I am extending it to all the other PGs as well as consultants. Thank you very much for attending these lectures and encouraging me and complimenting me every day. COVID-19 medications in pregnancy are almost the same as we would use in general population, but we must use caution with some drugs. We should know the effect of those on mothers as well as fetus. That is the reason why I am talking about this today. The treatment of COVID 19 during pregnancy is a challenge due to potential adverse effects of several drugs on fetus and neonate. Also, clinical trials are not conducted among pregnant women frequently for safety reasons. As you know, pregnancy is a high risk group or a special group whenever we conduct a research. You can't be just doing research on pregnant and children because of ethical issues. This implies that drugs which might be effective in general population cannot be used for pregnant women due to the lack of knowledge of side effects in them. Furthermore, treatment of viral infection is a challenge for physicians due to the elusive biological behavior of the viruses. As you know, we have seen many variants already, though most of them will have similar effect, but then the treatment evaluation is evolving every day. I remember giving the first talk on COVID in 2020, and I can see a lot of changes in my PowerPoint presentation from then to today. It is 2022 January. I gave it in March, and now in 2 years, so many things have changed. We have become a little wiser, but not there yet. The drugs that I will be addressing today are routinely administered antenatal or postnatal drugs. Can we give them? Antivirals, Remdesivir, Favipiravir, Lopinavir, Ritonavir, corticosteroids, anticoagulants, interleukin 6 inhibitors, others like Ivermectin, hydrochloroquine, immunoboosters. Most of these things are now more or less clear to all of us. This lecture would just reconfirm that, and those who didn't know, you may know this. First, let me talk about routinely administered antenatal or postnatal drugs. Can we continue to give them? I'm not talking about the usual hematinics or calcium. Of course, they can be given. Vitamin B complex, vitamin C, vitamin E, all those things can be given. I'm talking about routine antenatal corticosteroids, which we consider whenever we are fraught with preterm labor or threatened preterm labor. For lung maturity, before 34 weeks, we give routinely corticosteroids in high risk patients. For lung maturity, because of the clear benefits, administration between 24 plus 0 by 7 and 33 plus 6 by 7 weeks in patients at high risk for preterm birth within 7 days, ACOG and most of the other, they tell that you better continue with these recommendations. So you can give. That's why my color coding is such. The green means you can give, red means you cannot give. So antenatal corticosteroids are okay. Continue to give. But they are not advised between 34 0/7 and 36 6/7 weeks, as neonatal benefits are less clear. Usually there is no need to give after 34 weeks. That's what we say even in non-COVID patients, right? So there is no clear advantage, so it is not advised. Not because they will harm the patient or the fetus, but since the benefits are less clear, why unnecessarily give? All of you know, corticosteroids in the first week of COVID can do more harm. It may be actually considered later when there is severe lung disease. When there is a lot of inflammatory reaction going on, corticosteroids can compromise the situation by suppressing our immunity. So that is the reason. Only if it has clear benefit, go ahead and give between 24 to 34 weeks. After that, not required, not advised. Caution must be applied among women with critical illness. As I said, if they're in the inflammatory phase, this can compromise their situation. But later you may want to give it if there's a lot of edema and other things. The second routinely considered as a neuroprophylaxis. The previous one is a lung prophylaxis. This is the neuroprophylaxis, also considered as the prevention of convulsions, magnesium sulfate. In women with respiratory compromise, magnesium sulfate for maternal seizure prophylaxis and or neonatal neuroprotection should be decided on case-by-case basis. It may be dangerous to the mother because already she is having respiratory compromise, and all of us know that one of the side effects of magnesium sulfate is respiratory compromise. But if you think that the baby is going to benefit by that, very preterm baby, 30 weeks, 31 weeks, for baby's neuroprophylaxis, or if you think she is going to throw a fit, now you have to decide between, is it worth allowing her to throw a fit or to compromise with little bit of respiratory compromise existing in her. So that is the meaning of case by case. So you may have to discuss with the physician the respiratory condition of the patient, and you have to take a decision regarding prevention of eclampsia or neuroprophylaxis of the baby. I hope I am clear. Since the drug may further depress respiration, that's what I just now said. Consultation with maternal fetal medicine and pulmonary critical care specialist is advised. Please involve as many people as possible in a COVID care, especially in a pregnant lady. So you have to consult internal medicine or critical care specialists. Also, you must consult the maternal fetal medicine consultants. The next thing is low dose aspirin. This is given for the prevention of maybe eclampsia, not totally, but let's say to decrease the severity of preeclampsia or even prevention of FGR. There is insufficient data to recommend against low dose aspirin prevention of placentally mediated complications. What it means is go ahead and give, doesn't matter. Those with suspected or confirmed COVID-19, the decision to continue should be individualized. Again here, if the patient has problem, you cannot say don't give or give. You have to individualize the situation. Continuing preeclampsia prophylaxis is likely not worthwhile in severely critically ill patients or near term. If she is near term, stop aspirin, deliver her. Or if she is critically ill, preventing preeclampsia is not important. Saving her life is important. I hope it is clear. Every drug, every time when you give, you have to weigh the pros and cons. Always the preference is for saving a life first, and then preventing a complication, and then rest of it. What about NSAIDs? Ibuprofen, usually given for pain as a painkiller. Not only just pregnancy related pain, pain related to any other, maybe even a toothache. The concern about possible negative effect was raised by anecdotal reports of a few young non-pregnant patients who received ibuprofen early in the course of infection and experienced severe disease. This is not general population, few anecdotal reports only. So, European Medicine Agency and WHO do not recommend avoiding. Green means you can give, as I said. So the sentencing is little tricky. Do not recommend avoiding means there is no contraindication. NSAIDs in COVID-19 patients when clinically indicated. So give. No contraindication to use NSAIDs for postpartum analgesia, episiotomy pain, postoperative pain. Give. No problem. What about tocolytics? In women with known or suspected COVID-19, this may be considered again on case-by-case basis. You can't say don't give or go ahead and give. Weigh the pros and cons. For example, if you want to give nifedipine, you can think whether it is worthwhile giving nifedipine or does it harm. If it doesn't harm, you can go ahead and give. There are no COVID-19 specific contraindication even for indomethacin. Indomethacin is something like an NSAID. In the previous slide, I already said NSAIDs can be given. So if you consider this, we hardly give indomethacin as a tocolytic. Maybe in a cardiac disease, we consider this. In all other situations, our choice of drug is nifedipine. We can give. Routine supplements. Right in the beginning of my lecture itself, I said routine supplements. There is absolutely no contraindication for iron and folic acid, calcium and vitamin D, vitamin C, E, zinc, B complex. Should be continued, not just give. The sentence is should be continued. Green, bold, big letters. After this routine antenatal and postnatal drugs, I now come to the antivirals. We have already heard of these drugs many times. Let us now look at them. Remdesivir, it was a hero in 2020 and then it suddenly became a non-hero. In pregnant women seems to be safe based on limited evidence available from small studies. May modestly speed up recovery time, but no data exists on possible teratogenic effects and secretion in breast milk. The decision regarding use in pregnancy has to be made based on risk-benefit analysis. It's a different wording. Instead of saying case by case or individualized, they say risk-benefit analysis. Look at the risk and benefit. But please remember, we don't have data on its teratogenic effect and whether it secretes in the breast milk and thus affects the neonate. Mother, maybe yes. But then WHO came out in November 2020, in the same year it became hero, said, don't give it. It recommends against the use of Remdesivir in COVID-19 patients. We are in 2022. So no question, whether she's pregnant or not pregnant, there's no role for Remdesivir according to WHO. What about Government of India? It has to follow WHO. Currently, use of Remdesivir is not recommended in pregnant and lactating women. They are not talking about non-pregnant, but they are very clear in pregnant and lactating women do not give because we are not sure about its teratogenic effect, not sure whether it is secreted in the milk and affect the neonates. What about Favipiravir? Favipiravir is contraindicated in pregnant and lactating women, as well as in men and women who wish to conceive due to its strong teratogenic effect. We don't know about Remdesivir, but about Favipiravir, there is already proof that it can be teratogenic. So it is not only contraindicated in pregnant women, women who want to conceive, and even their husbands should not take this. Effective contraception must be advised before prescribing the drug to women in reproductive age group, because we don't know, they may suddenly become pregnant. So if you are using Favipiravir, you must use contraception. You must advise contraception. However, Government of India has removed it from the list of drugs for COVID-19 in June 8, 2021. So just don't bother about all these things. It's been removed already by Government of India. So Favipiravir is also out. Remdesivir is out. What about Lopinavir, Ritonavir? This combination has been assigned category B3. A small amount of drug crosses the placental barrier, but the odds of congenital malformations are not increased. So a systematic review involving 2675 women treated with this combination did not experience increased adverse pregnancy events like preterm delivery, preeclampsia, and placental pathologies. However, should be used during pregnancy only if clearly needed and the benefit outweighs the risk of fetus. There are different phrases of telling the same thing. Individualize the drug. Look at the risk-benefit ratio. See whether it is really outweighing the risks. Oral solution should not be used during pregnancy due to the ethanol content. This particular solution will have ethanol content. It contains 42% ethanol and 15% propylene glycol. It's almost like drinking probably whiskey or rum. Not advised. Contraindicated in patients with previously demonstrated clinically significant hypersensitivity. The hypersensitivity is usually because of the vehicle that is used to deliver the drug. If that's been there, don't give it. This is the March 31st, 2021. So now I come to the drugs that are used to treat the complications of COVID, not the antivirals, but the disease of it, the inflammation of it. Corticosteroid as a treatment, not as an antenatal steroid for lung maturity, I am talking about. World Health Organization talked about dexamethasone. It said, give it. In fact, it strongly recommends corticosteroids orally or intravenously for the treatment of patients with severe and critical COVID-19. Of course, not in the first week, but later when it becomes a severe disease. Dexamethasone, hydrocortisone, or prednisolone. WHO advises against corticosteroids in the treatment of patients with non-severe COVID-19. So it's not a blanket permission. Severe and critical, strong recommendation. But non-severe cases advises against it. So be careful, be clear about all these things. Unless the patient is already taking this medication for another condition, for example, she has got SLE or something like that, then of course don't stop it. That will create the problem. But just COVID-19 mild disease, don't start. Anticoagulant actually has made a big difference in COVID management. Initially, we didn't know what actually COVID was. Later, we came to know it causes really this coagulation problem. So anticoagulants became the mainstay of treatment. What about anticoagulants in pregnancy with COVID? There is an increased risk of thromboembolic events in COVID-19 patients. Pregnancy is a coagulogenic state. We all know that. So with COVID-19, it increases. So higher D-dimer levels, other coagulation markers, and numerous cases of pulmonary thromboembolism reported. As pregnancy is thrombogenic condition, It is strongly advised to immediately start prophylaxis in all pregnant women with COVID-19 unless there is a clear contraindication. Maybe if she's already having, the bleeding disorders or something, she's bleeding heavily, or she's having a DIC, don't give it. But otherwise, you have to give. Strongly advised, green color. LMWH must be preferred. Stop 8 to 12 hours before delivery and restart after 8 hours. This is almost the same recommendation as we use anticoagulants even in heart disease or otherwise. It is advised to continue this prophylaxis 4000 IU daily during the puerperium until the patient is still positive. Don't stop it just like that. Continue it. Because even postnatal period, it is prone for DVT and all other kinds of coagulation problems. Heparin does not cross the placental barrier and its use is considered safe during pregnancy. What about interleukin 6 inhibitors? Its administration appears to be relatively safe in pregnant and lactating women. Why the slide is not moving? We'll wait for it. Okay, so its administration appears to be relatively safe in pregnant and lactating women. In the recent EMPA-CTA trial, administration of tocilizumab reduced need for mechanical ventilation among COVID-19 patients with pneumonia. So what it means is you can give this. Then I talk about other drugs, miscellaneous. Paracetamol, give it, should give it, because hyperthermia during organogenesis may be associated with an increased risk of congenital anomalies, especially neural tubal defects and miscarriage. Temperature is not good in the first trimester, second trimester, third trimester, and in labor. The most important thing is to reduce the temperature. Acetaminophen, even in first trimester, has been shown to be very safe and may attenuate the pregnancy risk associated with fever exposure. Give. HCQ, again, this is the one who became a hero and then became a zero. All of us know about this. Though safe in pregnancy, for other reasons we do give. In a RPL we give this, and of course it can be given for malaria and other things, but clinical trials confirm that hydrochloroquine does not prevent illness or death from COVID-19. Hence, WHO does not recommend it anymore. Even Government of India followed suit. It removed it from the list of drugs of COVID-19 June 8, 2021. Ivermectin, no safety data, not approved by FDA, not recommended by WHO. Higher doses may result in actually multiple adverse effects which can be harmful to the mother and child's health and can result in poor pregnancy outcomes, thus discourage its use in pregnant women. Ivermectin. Government of India removed it from the list of drugs for COVID-19. Antibiotics. What do you think? Only if there is secondary infection. Just because COVID is a viral infection. No need of giving antibiotics. When we are worried, when we are not sure of giving antivirals, why do you give antibiotics? Unless there is secondary infection. Azithromycin, cephalosporins are safe. We know that. We give it for other conditions. H1N1, we have given plenty of azithromycin. Any other respiratory problem? But do not give amoxiclavulinic acid. It is contraindicated. So we all know this. This can cause in the child or in the neonate the enterocolitis. So we should not give this combination. Immunoboosters, multivitamins A, C, E, and minerals, magnesium sulfate, zinc, phosphorus are safe in pregnancy and lactation and may be given. That's actually is given for all COVID patients in plenty. Others not recommended by us. Now, I think Dr. Preeti Mehta, PG from I think Batinda, she told me, sir, please talk about vaccination as well. All of us know vaccination is safe. It can be given during pregnancy. Pregnant women, in fact, should take COVID-19 vaccine. WHO recommends vaccination in pregnant women when the benefits of vaccination to the pregnant woman outweigh the potential risks, such as pregnant women at high risk of exposure to COVID-19 and pregnant women with comorbidities that place them in high risk group for severe COVID-19 disease. Better to take vaccine. When? Anytime. First trimester, second trimester, third trimester. Not contraindicated at all. If a pregnant woman has already had COVID-19, when should she be vaccinated? Okay, that's a good question. In case a woman has been infected with COVID-19 infection during the current pregnancy, then she should be vaccinated soon after delivery. We have seen those who are infected, recovered, received vaccination. Those who received vaccination got reinfected. 1 dose, 2 dose, 3 dose also we have seen people getting infected, reinfected, but doesn't matter. But what is the benefit then? Vaccination is going to make the disease milder. We get the better immunity to fight it, and mostly it goes away as a mild disease. Side effects: COVID-19 vaccines available are safe, and vaccination protects pregnant women against COVID-19 illness or disease like other individuals. So they are safe, nothing to worry. Based on current knowledge, experts believe that COVID-19 vaccines are unlikely to pose a risk to the pregnant person or fetus. Like any medicine, it also may have some side effects. A vaccine may have side effects which are normally mild. After the vaccine, she can get mild fever, pain at injection site, or feel unwell for 1 to 3 days. Nothing serious, nothing to worry. Take rest, take paracetamol, take tender loving care from the husband. The long-term adverse effects and safety of vaccine for fetus and child is not established yet, however. Nobody knows. It's been there in the world only for 2 or 3 years. How do you know about the long term? What are the contraindications? Side effect is one thing, or complication is another. But are there any contraindications? As for the general population, pregnant women should avoid vaccination in the following conditions: anaphylactic or allergic reaction to the previous dose of COVID-19 vaccine. Suppose she had taken first dose and in between she became pregnant. Now she is due for second dose, and in case she had had anaphylactic or allergic reaction during the first time, better not to take this time. Anaphylaxis or allergic reaction to vaccines or injectable therapies, pharmaceutical products and food items in general, better not to take during pregnancy. Vaccine is temporarily contraindicated in the following conditions. If you are already diagnosed COVID-19 infection, defer for 12 weeks from infection or 4 to 8 weeks from the recovery. It all means the same thing. Like in one of the earlier slides I said, if she's infected during pregnancy, give it after delivery. So if you are infected currently, defer it for 12 weeks from the infection or 4 to 8 weeks from the recovery. If you are having active COVID-19 infection, of course, when we have said in the first sentence, defer it, So temporarily it is contraindicated. COVID-19 infection treated with anti-COVID-19 monoclonal antibodies or convalescent plasma. Again, it is temporarily contraindicated. Give a good gap and then probably you can give it again. So to summarize, of course, if there is COVID during pregnancy, it's mainly supportive treatment, which consists of mainly paracetamol and maybe some multivitamins. They are not at all contraindicated. As for corticosteroid, if it is a severe disease or a critical disease, you must give it. If it's a mild disease, there is no need to give it. As for anticoagulants, definitely they are indicated because pregnancy itself is a coagulable state and it should be continued even after delivery. Only during the time of delivery for 8 to 12 hours you stop it temporarily. Other drugs, steroids in moderate to severe situations, as I said already, anticoagulants if risk of thrombosis is high. Routine drugs are always welcome. Vaccination is also given during pregnancy. Whereas most of the other drugs like Remdesivir, Favipiravir, and Ivermectin, and even HCQ, these are all now contraindicated. They are removed actually from the armamentarium of COVID treatment in general. So why do you give it during pregnancy? Thank you very much. I cannot claim that I have covered entire gamut of the drugs that are used during pregnancy infected with COVID-19. And I cannot say the last word has been already said because there's lots to be still understood. Thank you very much for your continued patronization of this. Tomorrow I will come at 7:30 with another topic.